Today we have two very favorite friends of mine moderating this session, Dr. Parikshit Sharma and Dr. Ullas Panduragi. And as soon as Deepak is able to put everybody on mute, we can start the session and the case discussions. Dheeraj, can you please put everybody on mute? Okay, the moderators and the speakers can put themselves on. And so over to you, Parikshit and Ullas, please.
So let me just welcome Dr. Parikshit to this web series and to take charge of this whole program, at least the first topic by Dr. Shunmuga. And before anything, I think we are proud of two things. One, Parikshit's association with us, a pioneer with physiological pacing. And today he is going to be moderating one of the fantastic implanters of physiological pacing in the country, and that is Dr. Shunmuga. I think this combination is making me feel so very proud. And let's also congratulate Dr. Shunmuga and his team for the first ever time in the country, original series of a device, getting published in one of the most influential journals. I think is a big achievement, if you ask me. So I think we have congratulated enough, but nothing can be more than Dr. Parikshit is today, and he is moderating his presentation. So with this, Parikshit, I think you can talk a little bit about your association with Shunmuga and make his talk to be continued.
Sure. Well, first of all, thank you everyone for giving me the opportunity to be a part of this. I know that it's been a little bit chaotic here in the US. We've been doing a lot of these COVID ICUs and things, so I haven't been able to get on a lot of these, although I wanted to. So thank you, Vanita, for pushing me to set this up. I truly appreciate it. And I have to say I'm truly admiring Dr. Ullas's new French beard look. It's motivating, so I like it.
I was inspired by you, maybe.
Oh, is that? And Shunmuga, we all know that he's not just a great implanter, but also very, very humble human being. And it's very nice to be able to be associated with him. And we've done some work together on a recent trial that was presented at Heart Rhythm, and hopefully we can continue this collaboration not just with him but with many more implanters all across India, and that's hopefully what we can achieve through all of these webinars and future interactions. Hopefully at some point things will open up and we'll be able to physically see each other again, because I'm already having some withdrawal symptoms. So I'm also looking forward to the other two presentations, because it sounds like we have a interesting pathway case and a VT case, both of which sound very exciting. So I'm looking forward to the whole thing. Well, I won't take any more time. Let's get started just so we can stay on time. Shunmuga, over to you.
Shunmuga, are you there? SS? SS, are you there?
Am I audible?
Yes.
Yes, you are audible now.
Yeah. Thank you, Ullas sir, and thank you, Parikshit sir, and a big thanks for both of them, because I think the first ever physiological pacing which I've seen was done by Ullas sir in Parikshit sir in Ullas sir's lab. So this journey in fact started there in January 2009. So today I'm here to present two important cases of left bundle branch pacing. So one of this case is very, very important because it actually deals with a complication of a left bundle branch pacing, which is, though very rare, it's very important to know that complication so that it can be avoided easily whenever you are doing the procedure. So this is a story of a 65 years old female who was presented to us with a recurrent heart failure hospitalization. So she was having functional class 3 symptoms. Her coronaries were normal. Her echo was a typical non-ischemic dilated cardiomyopathy with EF of around 28%. Her LV internal dimension was 64 millimeter. She was a diabetic, and ECG showed a complete left bundle branch block. QRS duration was around 160 milliseconds. So we have discussed the option of both LBBP and CRT with them. And of course, they have opted for a dual chamber left bundle branch pacing in view of financial constraints. We usually put a groin catheter so that we'll have a marker for a distal raise bundle as well as backup pacing, so that if inadvertently right bundle is getting injured, so we can have a backup pacing. So what we have observed is whenever we are doing a bundle branch block correction for DCM LBBP, almost always the HV interval is prolonged, usually more than 70 milliseconds. In this patient also, the HV interval was around 74 milliseconds with an age of around 99, and QRS duration was 163 milliseconds. So this is how we usually do the procedure. So I usually keep the sheath, the RA, and then take the sheath without the dilator into the RB, and keep the sheath along with the lead just below the Heisman catheter, so that it will be just opposite to the side of the bundle on the RB side. So the important landmarks here are the tip of the Heisman catheter, which will tell you the distal extent of the Heisman bundle, the RB apex, and you may have to imagine a line which connects the distal Heisman bundle to the RB apex, and you have to work around this area. It's probably around 1 to 1.5 centimeter. That is where we also screwed. So we gave rapid turns, and we could demonstrate the QR pattern in the left bundle area while pacing that area. And LV80 was around 78 milliseconds, which was good enough for a left bundle capture.
Excuse me, Shunmugam, can you hear me? Can you hear me, Shunmugam?
Yeah.
Yeah, see, there is one notification, which is shown. Yeah, there's one notification.
Am I audible, sir?
No, this is Dr. Ullas. There's one notification comes there on your screen. People are asking, Karthike specifically is asking you to hide that. It is, it is hiding some of your traces.
Oh, is it? I'll see, sir. I'll do that.
All you have to do is press the word hide. Yeah. Thank you.
Yes, thanks.
Yeah, now it's okay?
Perfect.
Okay, thank you. So we have started a routine area, just 1.5 centimeter below the displacement catheter. And once the lead was screwed in, so we could capture the left bundle. We can see the QR pattern lead V1. The LB80 was around 78 milliseconds. And everything was looking good. The threshold was around 1.25. So the initial implantation threshold at the time of initial implantation, you can have a little higher threshold, which will come down probably in another 5 to 10 minutes. The only odd point was the impedance, which was around 380 ohms. So we usually won't accept an impedance of less than 500 ohms. What we try to do is pull out the lead and try to implant at some other area. So this is what we were also aiming while getting the impedance of 380 ohms. But what happened, all of a sudden, the patient developed angina, diaphoresis, hypotension. And the ECG showed this. So you can see the baseline ECG, which is a complete LBBP. And you can see the ECG. The patient has significant elevation in lead 1, lead AVF, with reciprocal ST depression in 2-3 AVF. So the patient developed STEMI, and she was having angina as well as a fall in blood pressure. So all we have to do is we have to remove the lead immediately, because I know that I have produced some sort of arterial injury. So I've removed the lead and I've kept everything ready for doing coronary angiography and watching for the symptoms. But fortunately, the patient's chest pain resolved and the ST segment gradually settled over a period of 5 to 10 minutes. So though I thought of doing an angio before implanting the lead, since the ST segment settled and the BP settled and the patient also shared that the angina has gone off within a period of 5 to 10 minutes, I thought of repositioning the lead and then going and looking for what the coronary abnormality has. Though she had a normal coronaries, which was done a couple of months back, this time definitely I know that I had produced some sort of arterial injury. The lead was removed and it was implanted at a little different site where we could show the selective as well as non-selective capture of left bundle. Here you can see usually this non-selective to selective transmission occurs at a near threshold output. So this patient's threshold was around 0.5. So you can see at till 0.7, there's a capture of local mechanism along with the left bundle. So you can see the local electrogram showing a pacing artifact followed by the ventricular EGM. So once the output has been reduced from 0.7 to 0.6, you can see the local ventricular EGM here distinctly from the pacing artifact. You can see subtle changes in QRS morphology also. So this confirms that I've captured the left bundle. I did angio just to be sure that what sort of injury I have produced. I could not see any occlusion of the diagonal branch because the elevation was predominantly in lead 1 AL and reciprocal depression 2-3 area. But what I could see is, so this is my final lead placement site. This is initial lead placement site. There was a septal branch, large septal branch, which was coming down, and it was there in the area where the initial lead was screwed. You can see here, so this was the large septal branch which was coming here, and my initial implantation site was here in RIO, and LAO this is here. So all I did was remove that lead from that area and implanted it a little below. So probably we thought that the arterial injury might be because of a coronary vasospasm. The lead might have hit the septal arterial branch, which would have produced a instinct spasm of the coronaries that would have produced ST elevation. And the second possibility is the impedance have shown that the impedance was 350 ohms. So I could have perforated the septum and the lead tip might have had a microemboli which embolized into the coronary circulation. Since I didn't do the angio immediately, I took time because the ST segment settled. So by then the probable embolus might have got resolved and the diagonal artery might have got recanalized. So these are the only two possible reasons which we could think of. The third remote possibility is an aerombolism, which unlikely to have happened because my lead impedance was 350, but still my sheath was on the right side of the shaft. And I didn't do angio also. So the sheath angio also. So the probable possibilities are either a microemboli or some sort of coronary spasm, which would have produced intense constriction of the main artery. I got a beautiful QRS at the end of the procedure. The QRS duration was 110 milliseconds. And what we could reanalyze and rethink is that, so this is my groin catheter. So it's always better to have a groin catheter to have a localization. And this is how your conduction system will go. So this is a distal end of the his bundle. And this is bifurcating into your left bundle and right bundle. So this is the left posterior fascicle. This is left anterior fascicle. So whenever you are doing left bundle branch pacing, so you have to have an imaginary line from the tip of the distal his bundle to the RB apex, and probably you have to target an area of around 1 to 1.5 centimeter below the his bundle region. So what I have done is probably I would have gone a little more proximal. So my initial implantation was close to the distal his bundle lead, probably within the 1 centimeter region. So that might have produced some sort of coronary arterial injury. Other major thing which usually happen is right bundle branch injuries. So if your height of implantation is in line with the his bundle region, like the target should be just below the his bundle region. But suppose if you are playing around the region just in line with the his bundle area, then there is a high chance of injuring the right bundle and high chance of producing complete heart block in those patients with left bundle branch block. So it's always better to keep your sheath just below the his bundle region. Avoid playing in this area where your right bundle will be, because undergoing injury will produce definitely complete heart block in those patients with DCM LBBP. So these are the two areas which you have to avoid. The area which is closer to the his bundle region, where some major septal arterial branch might come, and the area which is in line with the distal his bundle catheter, or probably in line with 0-degree line with the distal his bundle signals, where your right bundle will be. So if you are going to avoid these two areas, probably you may have a reduced incidence of complete heart block while implanting left bundle branch pacing. As expected, the trophy peaked to around 230 picograms or 0.23 nanograms per ml, though the patient didn't have any new onset regional wall motion abnormality. They're perfectly okay, and she got discharged after 2 days, and her LVF improved to 45% at the end of 2 months. So she responded well as expected for a left bundle branch pacing. The only problem is she had some transient elevation. So what I would like to stress here is, so whenever you are implanting a lead, avoid pacing an area which is very close to the his bundle. Though sometimes you may not be able to penetrate the lead because tricuspid leaflet might be here, so you'll not be able to place the lead deep inside this area. But still, if you are playing around this area, there is a chance that you may injure the artery. And if you are playing in this area, there is a chance that you may damage the right bundle. So always safe to keep 1 to 1.5 centimeter below the distal his bundle signals. So that is about my first case. So any comments about my first case?
Yeah, so Shunmugam, let's ask Parikshit if he has some questions or comments, and post that, I may actually chip in.
Yes.
Parikshit, please.
Yeah, sure. Great case, Shunmugam. I know this is already published in Heart Rhythm case report, so congratulations.
Thank you, sir. Thank you, sir. Thank you, sir.
Yeah. So yes, this is there are potential issues that can come up with left bundle branch pacing as well. And just like any other implant technique, it's important to be aware of what potential issues you might see. We have a paper that is hopefully going to be online soon that talks about all potential complications with left bundle branch pacing, but excludes this one. So this sort of complements that in that way. So first question I had was, did, the advantage you have in this case is that you have a His bundle EP mapping catheter. Did you actually pace the His bundle catheter at a high output to see if you corrected the left bundle branch block?
That's correct.
No, sir, I didn't do actually. I just went ahead with putting a left bundle lead. I didn't do that His bundle pacing to look for SP correction of LBBP. I didn't do that.
So there is an advantage. If you're going to be doing this in all your cases, then remember, in a patient with a left bundle branch block, if you can actually correct the left bundle branch block, particularly if you can correct it with selective capture, then you might be able to appreciate the potential when you do a left bundle branch pacing. So that's an added advantage. So, we just finished writing a paper with Dr. Wong looking at what are the criteria that we need to identify? What are the more specific criteria to help confirm left bundle branch capture? And I think the gold standard is really finding a left bundle potential. So if you can actually pace the His catheter at a higher output, recruit the left bundle branch block pattern, and allow conduction over the left-sided conduction system, you might be able to demonstrate a left-sided potential when you implant your left bundle pacing lead. So that would be one. Another thing that would be valuable is to actually look at some of the other things, which is the LVAT, which remains fixed and stable at different outputs. So in addition to the impedance trends, which we look at, as we're screwing in through the septum, the impedance increases and then it starts settling down and decreases. We don't like it to drop too much. Just like Shunmuga said, I usually have a threshold of 400, 450. Anything lower than that is too much of a drop in impedance. So you want the impedance to come down a little bit. It may go up to 800, 900, even 1,000, but you want it to settle down a couple of hundred ohms below where the peak was, but it shouldn't drop too much. That would be an indicator that you're probably too close to the left-sided septum, or maybe may have perforated or micro-perforated the left-sided endocardium. So impedance is a good marker. Looking for a left bundle potential is sort of the gold standard. And the LVAT, a fixed and a short LVAT, I usually do in my lab, we pace at 10 volts, 5 volts, 2 volts, and demonstrate that the delta in the LVAT is less than 10 milliseconds. If it increases by more than 10 or 15 milliseconds by decreasing outputs, then you're probably not on the LV endocardium and you're still LV septal pacing, not truly LV endocardial pacing. Because LV septal pacing itself can give you a right bundleoid pattern or a QR and V1, and you would feel like that is sufficient, but you're not truly capturing the left-sided conduction system. We don't really know the answer whether, LV septal capture is sufficient. It might be okay in patients that don't have a cardiomyopathy and just have a regular pacing need. But in patients with an underlying cardiomyopathy and left bundle branch block, we want to try and definitely capture the conduction system in order to give them the most advantage possible. The one other thing, as Shunmuga already pointed out, was, in this particular case, and for various other reasons, if you're doing left bundle branch pacing, I usually tend to advance the sheath all the way into the ventricle and then pull it back to that area that may be 1 to 1.5 centimeters away from the His bundle. Reason being, because if you just, oftentimes people will not, in the US, we don't always use a mapping catheter from the groin. And you'll mark the His fluoroscopically, and then you'll just advance the lead and the sheath about 1 to 1.5 centimeters in, and you might actually get the septal leaflet of the tricuspid valve pinned. So you don't want to do that because that'll make it difficult to advance the lead. And even if you're able to successfully get it, you pin the septal leaflet to the septum as you're getting the lead in. So that will result in tricuspid regurgitation. So always go all the way into the ventricle and then pull back so you're free of any chordae, and that'll make it easier to drive the lead into the septum as well. And certainly I think very beautifully highlighted by Shunmuga in the diagrams. More proximally, you're likely to encounter the septal branch of the coronaries, and I'm not convinced. I think it would have been more valuable, Shunmuga, to actually do the coronary angiogram with the lead in place, so you could definitively demonstrate what was the mechanism of ST elevation. I think coronary vasospasm is a very feasible explanation, but could there potentially be injury, actual injury to a part of the coronary the septal perforators that we're not seeing in that angiogram that you performed, is a potential thing that does cross my mind. So it would have been valuable to actually do the angiogram while the lead was still in place before you moved it. But hey, at the end of the day, the patient did well, the ST elevations resolved, so it's likely that vasospasm is the most likely etiology or explanation for it. I think those were all my comments, unless someone has other questions.
No, I think we should be addressing some of the questions which are coming up here, Parikshit. So let's start about those questions. You know, they revolve around a few things, and that is something to do with the mechanism of this ST elevation. If we get back to that ECG, and I think many people can recall, there was a significant ST elevation in lead 1 and AVL, which are suggestive of not necessarily a subtle injury. Dr. Yadave, Dr. Yash, Dr. Anup, Dr. Suchit, they all are considering, you know, that could be another mechanism, you know, not necessarily what that was proposed. There seems to have been penetration into the cavity because the impedance was quite low, that's correct. But then the injury, or whatever the mechanism of ST elevation in lead 1 and AVL, if we can show one, it's seen here, and I'm not sure AVL also significant ST elevation was seen, which is unlikely to be a subtle injury. So, you know, somebody even quoting maybe an embolus when the lead went into the cavity, got into the coronaries, maybe. So that is one thing which Shunmugam needs to explain. And then there are a couple of things which I would like to again emphasize what Parikshit had told. You see, it is always better, you know, maybe Shunmugam has such a great experience, he thinks no waste of time, get into the deep septal pacing, don't waste time, but it's not true. 30 to 50% of the times in the LBBP can be corrected at the his bundle area. I think Parikshit knows, and you know, he has demonstrated it very well. So there are issues. So, you know, this particular case, I think, teaches us that, you know, you may not have to go deep in and then, you know, be done with it. Maybe you can try a little bit in the his bundle. So Shunmugam, let's answer some of the questions by the audience. Suchit, Yadave are asking you, why do you think it was a septal injury when the ECG signs suggestive of a different coronary territory? Shunmugam?
Yeah, the injury is predominantly in the diagonal territory because the elevation is in one AVL, and it has a significant ST depression in the lead 2-3 AVF.
Yes.
And so we thought of the diagonal occlusion, but while doing the angiogram, we didn't have any even minute features of having any diagonal flow compromise. So that is, of course, that one possibility is always there. Just share the screen again. The injury is predominantly in the diagonal territories. There's no doubt.
All right. Okay. All right. So, you know, I think let's not get into that. But Dr. Yash has got some question, but I'm not certain what he wants to mean, because at least I'm not very clear. He was talking about his bundle. I will read this question. If screaming near the his bundle area would be more likely to produce coronary artery injury spasm, then it should have been seen more commonly with his, you know, can you read the Yash Lokanaval's comment? I'm not understanding what he actually means.
No, I think what Dr. Yash is highlighting is that, you know, I think Shunmugam made a comment that if maybe he was more proximal than where he should have been, and maybe that's one of the reasons why there was potential injury or vasospasm as a result. But Dr. Yash is highlighting correctly that if that was the case, then we should have seen this more commonly with his bundle pacing as well. And I think with his bundle pacing, whether you're atrial or whether you're on the ventricular side, more often it's associated to the membranous septum, and there are not a lot of coronaries in association in that area.
Exactly.
In the muscular septum, you're more likely to have septal perforators. And Shunmuga, I'm not 100% sure that you can't have septal perforators even at a slightly more distal site. I think they're more likely to be higher, but I don't know if going proximal or distal, because these are millimeters or less than a centimeter away from each other, whether that truly would avoid. Absolutely, it just depends on the anatomy in a given patient. And I think, again, going back and looking at that ECG more carefully, I do agree this could be either embolism or vasospasm to a different branch as a response to the injury to the septal branch. That's a possibility that could potentially explain why the distribution of the ST elevation was in a different arterial territory, because it could have produced more extended vasospasm in the left-sided coronary arteries.
So Parikshit, because we got 2 more cases to come up, let's spend only 2-3 minutes more here. Whether this particular issue and this particular complication, which is probably rare, and on top of that, JP is asking a good question here about the lead extraction in the deep septal pacing. So looking into these some unknown territories, like some of these complications, plus we do not have lead extraction data or long-term data. So again, coming back, should we all try his bundle pacing really hard first and then go to the deep septal pacing? We would like to know once for all from you today.
I think many people think I'm biased when it comes to answering this question. I mean, I've been performing his bundle pacing now for about a decade, and I know a lot of people would think I look very young to be performing it for a decade, but I really have. And we know the downsides to his bundle pacing. We know the challenges associated with it. And the biggest challenge really is there is a subset of patients that demonstrate an increase in capture threshold from the HIS. And we know the extraction ability. We know we have answers to progression of disease processes, all of that. We know that there's enough data that's published on extraction of HIS leads where these leads can be extracted easily without any further damage to the conduction system. There is data from Dr. Vijayaraman where he's demonstrated patients that have come back for generative changes. I have demonstrated a stable and fixed HV, and even pacing at faster rates from the tip of these leads has not resulted in block, suggesting that in these patients with AV block, there was no distal progression of disease. So I think the biggest limitation currently with his bundle pacing, in my opinion, is the unpredictable increase in capture thresholds, which happens between 7 to 10% of cases, and about 3 to 4% of these patients end up needing a lead revision. So that is a limitation. But I think the way we've changed, or at least my and also Dr. Vijayaraman's practice, has been more so. Wait, I will be happy to share a link to the paper once it's published, but it basically talks about how we went about performing this. So what we really have done is with we start any patient that comes in for conduction system pacing, we start with his bundle pacing first. If we get a threshold for his bundle capture or for narrowing of the bundle branch pattern that is more than 1.5 volts at 1 millisecond, we don't accept it and we move on to left bundle branch pacing. And if the threshold is less than 1.5 at 1 milliseconds, then we will accept the site. We will check the threshold multiple times. And oftentimes in those patients, we're not seeing, or at least anecdotally, this is not published data, but anecdotally, I haven't seen need for a lot of revisions or increase in capture thresholds. In the past, we used to accept thresholds up to 2.5, and in patients that had a CRT indication or failed a BIV, we'd even accept up to 3 volts sometimes. But that's all changed. Now with left bundle branch pacing, we have a second modality that helps us achieve resynchronization by finding what is best suited or tailoring therapy to a given patient in a given situation. So utilizing that in the paper that we have under review that is hopefully going to be finalized soon, we demonstrated that when we changed that protocol to 1.5 volts as our cutoff, nothing more than 1.5 volts, we ended up performing left bundle branch pacing about 25 to 30% of the time. And that was, again, more so in patients that had more distal conduction system disease or had bundle branch block that was not correctable, or for a small subset of patients that were undergoing AV nodal ablation just because we were afraid if that would have an AV nodal ablation down the road, that it would be safer because we had a bigger area that we could perform AV nodal ablation on. So my current practice and our current practice in general is to look at conduction system pacing as an entity that has two different options at the present time. It's just like saying cardiac resynchronization therapy. Cardiac resynchronization therapy is whatever way works for a given patient. If a BIV, which again, BIV has more data. So again, it's good to go to what we know is acceptable as a gold standard with a lot of data to it. But if a BIV fails, most people will say it's okay to perform conduction system pacing. So whatever works for a given patient is probably what you should do. So if you are going to commit to conduction system pacing, my strategy is try HIS. If HIS gives you a high threshold, move on to left bundle branch pacing. This way, you're trying to give the patient the best of whatever option works for them, and potentially minimizing the need for complications. Again, we've seen, I showed you in my previous visit, a patient that actually perforated the LV septum in follow-up 3 or 4 weeks later. And that's a published case report in Heart Rhythm Case Reports now. So these sorts of situations can happen no matter how careful you are. The other issue that is also common, but people don't pay attention to, is, let's say, for example, you perform left bundle branch pacing as a strategy for cardiac resynchronization in a patient with left bundle branch block, or patients that have need for ventricular pacing and have a low EF. In follow-up, if that lead migrates micro and pulls back towards the right side of the septum, you're not capturing the left conduction system anymore. That is RV septal pacing. How is that providing benefit to a patient that has a CRT indication? How is that beneficial to a patient that has a left bundle branch block to begin with? The issue is there's a lot of implanters that don't perform those ECGs to look for it. And in our series of just about 60, 65 patients, we're now up to about 80 cases, but in just about 60, 65 patients, we identified 4 or 5 patients that actually the lead had pulled back a few millimeters and lost left-sided conduction system capture. The same thing if people were to do with HIS bundle pacing, they'll say, there's no HIS capture, the threshold went up, oh my God, this is not good therapy. But with left bundle branch pacing, that happens as well. It's just people are not looking for it. And you're not giving patients a benefit for CRT.
Parikshit, I think we will take one final question, and that's very important. And that would be, the answer from you, it could be yes or no, and that is from Dr. Yadave. The question from Dr. Yadave, would you still do BIV CRT, yes or no?
Biased answer, but I start with CSP first. And if that fails, that's when I put an LV lead, unless it's a patient with an IVCD, in which case I go straight to BIV.
Great.
For a patient with a typical left bundle or right bundle branch block, it's CSP. For a patient with an IVCD, it's BIV.
All right, great. Wonderful. I think, Vanita, we should be going for the next case. And before that, Shunmugam, as usual.
We have one more case from SS. We have to give him time for another case. He's going to present the second case.
All right. So, but then, we have...
We will make that as a short case so that then we can go to Suchit directly. Okay. Let's make that as a short case.
No. Hang on. Can we ask Dr. Shunmugam to finish it up, say, in 5 minutes? Just tell us verbally, if not presentation.
You are the moderator, you are the boss.
Because you see, we got to be discussing a little more extensively 2 more cases. They also, require time here.
SS?
So VT and
SS, can you finish the second case in 5 minutes?
Briefly tell us the gist of that particular, case.
Share your screen, SS.
Sure. I'll take just 5 minutes.
Okay.
So this is the story of a 71-year-old male with a recurrent heart failure hospitalization. He had atrial fibrillation.
You hide the notification.
QRS was
again. You hide the notification.
Oh yeah. Sorry. Yeah. So he had some sort of ischemic component. His coronary showed a medial 80% stenosis. His EF was around 38%. and a ventricular rate of around 140 beats per minute. The most important point here is around the mitral regurgitation, which is of moderate to severe in severity. So this is ECG. So many times this heart rate was around 140. It showed some incomplete right band pattern with a QRS of around 100-110 milliseconds. So this was echo, which you see the registration is very significant, probably of moderate to severe intensity. And you can see the myocardial thickness, and the frequency is more of a global. So it's predominantly of a valvular regurgitation with atrial fibrillation and fast ventricular rate. And the patient is having heart failure, one because of the regurgitation and another because of tachycardia myopathy. Most probably, though the LAD has a stenosis. So this is a LAD, and probable options are either to go for an MER with the graft to LAD with the medical management of atrial fibrillation, or to go for a valvular replacement with the CABG, and post-operatively, if you feel that AF is significant, then go for ablation and pacing. So we have opted for a third strategy where we feel that the regurgitation is purely because of a functional component, and if you control the rate, probably everything will settle, and once everything is settled, we can go for a PCA to LAD. So we thought of doing AVJ ablation with the left bundle branch pacing, and subsequently after stabilization, we thought if he's getting stabilized, then we could have planned, we can easily plan for a PCA to LAD. So this is his basal intervals, a QRS duration of around 115 milliseconds, and his HU was prolonged for around 63 milliseconds. So we could demonstrate beautiful non-selective to selective capture of the left bundle. You can see here this local lead electrogram showed a pacing artifact immediately followed by ventricular electrogram. Here you can see an isoelectric interval, and we can demonstrate a beautiful left bundle potential in the pacing lead. So once the lead is secured, then I've taken an irrigation catheter to ablate the AV node. So once the AV node is ablated, this rate is fixed, and we could capture the left bundle effectively after ablating the AV node. So this is post-pacing ECG, which showed a QRS duration of around 110 milliseconds, and with a QR pattern in lead P1. And subsequently, after a month, we did a PCA of LAD. It's a quite easy to direct stenting of the LAD. And we could show that this is basically this is supposed to go after 1.5 months. We can see the significant projection which was there before the procedure has come down to around 2+, and its EF of settlement of the ventricular rate improved from 38 almost 45 to 50%. It's absolutely asymptomatic now. And so this is one way of dealing this functional mitral regurgitation problem in patients with pulmonary atrial fibrillation. So before the conduction system pacing, AF with fast ventricular rate is quite difficult to manage, because pacing the right ventricle and ablating the AV node is creating one disease of chronic RV pacing, or treating one disease for the permanent atrial fibrillation. But with the advent of physiological pacing, this atrial fibrillation with fast ventricular rate is getting a better treatment. And if you find significant mitral regurgitation, assess the valvular component thoroughly, so that if there is no rheumatic or any other structural problem in the mitral valve, then probably if you're correcting the fast ventricular rate, everything will settle, so that we can avoid a possible valve replacement. I finished my case. Probably can give some comments. Thank you.
All right. So I think Shunmuga, we will wait for Parikshit Sharma to come in, and let Parikshit Sharma take only 2 minutes to make the comments on this case, and then we will invite Deepak.
Yeah. All right. Just a couple of quick thoughts. I think the first thing is I think it's more important to make sure that the mitral regurgitation is functional, because if it is truly valvular, then it may not improve. And again, there's a component of how dilated the left ventricle is. We know that with BiV therapy or with resynchronization therapy and control of ventricular rate, there is enough data that suggests that functional MR can improve significantly, and these patients don't really need valvular surgery. And so that's exactly what Shunmugam has shown in this case. And we have a bunch of cases where that's exactly what we see. We try resynchronization therapy with CSP as a first strategy before we proceed with open chest surgery, because that's less invasive as compared to correcting underlying dysynchrony and RVR. I think there was another question about.
Parikshit, yes. I would like to read a couple of comments and the questions here. Kumar Narayanan and Anup Gupta, they are talking about restoration of the sinus rhythm here.
Yeah.
For example, AF ablation, could it have been considered by Kumar Narayan? I think he implies percutaneous. Anup Gupta goes one step further. Mitral valve repair during the surgery, and then a graft to LAD. You see, these are all quite valid options here.
Yeah, I mean, if this patient was in the United States, I think I would have performed atrial fibrillation ablation as my first strategy, not surgically, but catheter-based. We have enough data that suggests that controlling the atrial fibrillation in and itself and restoring sinus rhythm will help this patient, and might even improve the LV ejection fraction and mitral regurgitation. So that's the least invasive option by avoiding a permanent implantation of a device in this patient and performing an AV nodal ablation. So that would be my first choice, at least in the United States. I'm sure there were certain economical or other limiting factors from Shunmugam's standpoint, but that's what I would have done.
Yeah. So the final comment could be from me. If at all, if this is an atrial fibrillation case and relatively narrow QRS and a significant MR and uncontrolled rate, one has to be Shunmuga Sundaram, to dare this kind of procedure and an AV node ablation. I do not think this is like a commonly prescribed or a commonly adopted strategy. I think we've got to be really good at understanding this physiological pacing. Then only we can consider this. Shunmugam, very well done. The second case is, I think, an extraordinary and adventurous one indeed. So Vanita, I think we should be calling Deepak.
Over to Suchit is actually sharing this.
Okay, Suchit. So Suchit, Parikshit, you must be knowing Suchit very well. His comments and everywhere, even on Twitter, I think they're all read very much. Suchit Majumdar is one of the rising stars in the EP country. He thinks, beyond what all our comprehension is. So I think he's going to talk about atriovesicular or Maheim tachycardia, something interesting about it. So welcome, Suchit. Nice to have you here and share your case with us.
Okay, so I'm audible fully?
Yeah, very much, very much.
Okay. So thank you, sir, for the kind invitation and the nice words you spoke. Not with that. And also thank you, IHRS, for giving me the platform to present this case. Means it is not a great case in that, means it is just a atriovesicular pathway ablation, and I have just tried to discuss some points, how to recognize and how to ablate like that. So it is about a 36-year-old lady with who presented with us with recurrent palpitations needing hospitalization and adenosine termination, and the patient had a normal echo, and basal ECG was this ECG, which was nothing, no definite pre-excitation could be seen. But whenever you are seeing a ECG where you are not seeing good pre-excitation, you should think two things. Means whenever you have to search for it basically. So that is what is called as a subtle pre-excitation. We have to look at lead 1, AVL, V5, V6, and if you don't have, if you have loss of Q waves there, or if you have an RS complex in lead 3, this may indicate presence of right-sided pathway like an atriovesicular pathway. Also in left lateral pathways, as we know, because of less fusion, we may have a minimal pre-excitation. So these are the two places where we can have a minimal pre-excitation, and we have to search for it. This is another patient's ECG. Now, if we see this ECG, we can see that there is a very subtle pre-excitation with the loss of Q waves in 1 AVL, V5, V6, and we have to think of all these things, these two differential diagnoses when we look at these subtle pre-excitations. When we took in the lab for EP study, we saw HB interval of 32 milliseconds, not very less. And then we did an incremental atrial pacing. On incremental atrial pacing, we see a jump of the AV interval, means AV interval suddenly increases on pacing at 340 millisecond, and then we have a LBBP pattern of tachycardia with a normal axis. Not normal axis, maybe just 0 degree axis. So leftward maybe, but near normal axis. And then we go to the intracardiac part of this induction, this incremental pacing. We see that there is a sudden increase in the AH interval with development of this pattern where we have HV is 0. So it is a pre-excited pattern. So there is a pre-excitation which is almost suddenly becoming near maximal, and it is remaining so. There is no gradual transition from slowly from minimal to maximal pre-excitation. Then also we see that here in the pre-excitation, we see the sequence of his and the RV. That sequence has changed. Means initially it was his, then RV. But here we see when it is pre-excited, the RV comes early and then the his comes. So whenever we see the response is that there is a sudden change, and this sudden change is to a maximal pre-excitation is associated with a sudden increase of the P delta interval, and this may indicate a dual AV nodal physiology because there is a sudden significant slowing of the AV nodal conduction leading to a near maximal pre-excitation. There is also a sudden jump of AH interval, and sequence has changed, as I have mentioned. Usually what happens is that even in this part, this is also another case of atriovascular pathway. We see there is a gradual increase of pre-excitation with the increase of P delta interval. If it is a normal pathway, like a usual AV nodal pathway, the AV interval should remain same, but the AH should increase and HV should come down. But here we see with the increase of pre-excitation, the AV interval also increases. And that is a characteristic of this sort of pathways, which is a decremental conduction. That is the Maheim sort of pathways or atriovascular pathways. And in this patient, we did atrial extra stimuli where we saw a jump is there. And immediately after the jump, we have this near maximal pre-excitation. And apart from this, we saw that the pathway ERP was 240 milliseconds, but even after the pathway was blocked, there was conduction through the slow pathway of the AV node, resulting in AV nodal conduction. So, the fact that slow pathway conducts even after the bypass tract is blocked indicate that antegrade conduction was down the antegrade his. That is also important because it was coming down also. It was already a fusion. So ARP gives the following data. It gives the ERP of the pathway, AV node, fast pathway, slow pathway. But in typical AV pathways, fast pathway to slow pathway jump can't be appreciated as the AV interval remains constant. Here the jump can be seen because the pathway also decrements. And AV nodal conduction at the end of refractoriness proves that the QRS was a fusion all along, maybe balanced fusion. And his here was likely antegrade. If it is a retrograde his, the VH relationship would have been constant and the QRS morphology would have been constant. Now coming to the retrograde ventricular pacing, here we see the earliest is his, and there is a decrement we saw in different cycle lengths. So it was going through the AV node. Also we did a parahesian pacing to see that whether there was a nodal or an extranodal response, but here it was a nodal response on parahesian pacing. Here we see a wide QRS and a narrow QRS, and even with or without his capture, the VA or steam A interval was changing. So tachycardia was induced on incremental atrial pacing, and this tachycardia was almost over normal axis LBBP with a transition at V5. And in the intracardiac, we see that if we can see that the activation pattern, there is a right bundle activation followed by his activation in this case. If we see here, we can see the right bundle is activated and then the his is activated, and retrograde the his A is earliest. So how can we see the tachycardia axis in a atriovascular pathway? That depends on where the this atriovascular fiber inserts. If it inserts into the right bundle proximally, it can give a normal axis also. If it inserts into the ventricular myocardium near apex, it gives a leftward axis. And one may change to the other, means a normal axis may change to the leftward axis even with a proximal insertion if there is a retrograde right bundle branch block. Another example of an apical insertion of Maheim, here we see that it is a This is also another case where we have a Maheim fiber tachycardia, and here we see that the axis is leftward. So if we see the intracardiac EGM, we see a VH is long. Now, whenever you have a longer VH, it indicates it is a apical insertion because it takes time from the ventricle to the his. Now, if it is inserted above, then it is a parallel activation to the ventricle and the his. So VH interval should be very short if it is a proximal insertion. So it proves that there is an apical insertion of Maheim. There is no good right bundle potential also, and the tachy is also left-sided, left axis. Now coming to the determining the antegrade limb of a Maheim tachycardia or atriovesicular tachycardia, we have to give a septal refractory APC. That should not go through the AV node, but should go through the pathway. Now, how to time it? Because the his may be inside the QRS and it is difficult to find out often in an antidromic tachycardia, we can time it with the his A. Now, when the his A has appeared, it is expected that that will go down to the AV node pathway. So it should be refractory. Whenever APC is given after the his A has appeared. So that is called as a septal refractory APC. For example, here we have given septal refractory APC, and this septal refractory APC has pushed the next V. That is called as a post-excitation, and that is also a component of decremental pathway. So because of the decrement, it has pushed the next V, and subsequently it has reset the tachycardia. So if it pushes the V, it is definitely a part of the circuit, and it's definitely part of the circuit. And retrograde limb, we have already proven that there is no pathway also. We have proven the parahesian pacing. Next, we have done an atrial entrainment. The atrial entrainment was showing AVA response with a tonsil fusion, and ventricular entrainment was done to see whether it is a AVNRT with bystander or something, but that is less important because we have already done an APC. But ventricular entrainment showed that PPI minus TCL is very less, so it is a part of the circuit. RBF is a part of the circuit. Though there is some change in the QRS morphology between the pacing and the tachycardia. Maybe we are pacing slightly below from the place the Maheim is inserted. Now, if I'm coming to the ablation, we have to be very careful to map the tricuspid annulus. Usually, it lies in the 7-8 o'clock position in the LAO view, and we have to avoid bumping it. Now, bumping may be allowed if we are using a 3D mapping system, because the place we have bumped, we can go down to that place and we can ablate it. But in usual 2D mapping system, it will be difficult because we may have difficulty to locate the pathway after bumping. We have to take a sheath to the RA lateral wall. Just I will show you the fluoro. So, and the sheath should support the catheter, and maybe sometimes you can put the catheter like a halo catheter along the convexity of the RA in order to have a stable position while ablating this tachycardia. And what we have to look, we have to ideally do it under pacing to get a good pre-excitation. And we have to look a potential, which is the Maheim potential in that location where I have put the catheter. So this is from this case where I showed the case. And these other examples of Maheim potential. It is a sharp potential like a his. And it has two components. It has a two component from atrium to the Maheim potential and Maheim to the ventricle. So finally, we get automaticity when we ablate in the Maheim pathway, and after this automaticity, there is loss of pre-excitation. In this case, after ablation, if we have done an incremental atrial pacing, which again showed this sort of morphology, maybe a LBB morphology and tachycardia and pacing morphology, which was looking like a pre-excitation. We were initially frightened, but whenever we look closely to that, we saw that there is a difference to it. Here we see that before the ablation, the RV was early and the his activation was late. While here, when we after ablation, the his was early and the RV was late. So this was actually an aberrant conduction causing an LBB morphology, which was confusing. And finally, we could ablate this case. Thank you.
Suchit, great. You know what, Vanita, please give me permission here. The master of Maheim is with us, Dr. Yash Lokandwala. He already is commenting here some great points, something to do with the axis and what is its implication with respect to the pathway course. And he also talks about the ventricular overdrive pacing. Yeah, it probably did not make much sense unless you look at that HA interval during tachycardia and the ventricular overdrive pacing. Can we ask Dr. Yash to unmute and then please come into the discussion here?
Dr. Yash actually has a bad throat. I hope he's able to.
I think, okay.
Dr. Yash?
So he says that, voice issues.
Exactly. And you don't need permission from me for everything, Ullas. You and Parikshit are the moderators, not me.
No, but when Yash is around, what, I at least become dumb. So it's all right. Parikshit, you have some comments to make. It's like a teaching session on Maheim. I agree. Parikshit, will you please chip in and then make some comments here before we go to the
Sure. I mean, again, like you highlighted correctly, I think we have some very senior members that have much more experience with this. So, pardon me if I share any of my 2 cents, but Maheim tachycardias and Maheim pathways, it's interesting. I mean, the one thing that I'd always been taught is not to use this term loosely, because the original description of a Maheim, I believe it was in the 1940s, was about a nodoventricular fiber.
Yes.
And so we're very careful with trying to make sure that we specify atriovesicular. I think the term Maheim then got generalized to most accessory pathways that demonstrate a decremental conduction property, like you see in this case, and there are others that can result in similar decremental conduction. So I think the one other thing here would be you have an RV catheter. So what I usually do is, just to demonstrate the right bundle potential, which you were lucky enough to see during tachycardia, you can show that during atrial pacing as well, just to demonstrate, or atrial extra stimulus as well, just to demonstrate when there is a switch from prox to distal to prox. So if you pull the RV catheter back and record a right bundle potential on it, you'll be able to show that change in axis from His to RV to His, or right bundle to His. Just like you showed with the RV electrogram, it would be nice to have the right bundle potential there as well. And I think oftentimes, you're right, oftentimes ablating these can be challenging if you bump it. I know people struggle with it, and some people actually even have switched to cryo. And these can be anywhere from 7 o'clock to 11 o'clock, at least based on the descriptions. I've done a case that was at about 10:30, 11 o'clock on the lateral tricuspid annulus. So those are all very reasonable. And unless you find the M potential, you probably are not going to get a successful result, or at least that's what my limited experience has been. And it's more important to also ablate these on the atrial side. So as you look at your site of successful ablation, you have a big atrial electrogram with an M potential. And that's important because if you ablate these closer to the ventricular insertion site, oftentimes these insertions could fan out, and you might get one of the fibers, but may still have tachycardia, or may still have pre-excitation because you didn't get the atrial insertion side of these pathways. So those are just my few comments on the case.
Right. You see, you know what, Dr. Anup Gupta, who had been mentored by none other than Dr. Yash Lokandwala, has a great experience with Maheim. And I think he has got several publications with respect to the Maheim tachycardia. Suchit, Anup has a question for you. Did you ablate during the sinus rhythm or during atrial pacing? And what is your usual approach with the classical Maheim fiber? I mean, classical atriovesicular fiber.
Yeah, atriovesicular. So, sir, I think we should always ablate there when there is a significant pre-excitation. Means if the pre-excitation we don't get usual in the sinus, then definitely we should pace and get a good pre-excitation and ablate. Then we can get the Maheim potential better.
Yeah, that's what is your usual approach, right?
Yeah.
Okay. All right, so great learning from you, Suchit. Thank you very, very much.
Thank you.
Yeah, so Vanita, should we invite another bright star, Deepak Padmanabhan now?
Absolutely.
Yeah. So Deepak, always, brings in some very, very interesting cases. His talks are all quite educative, and he's going to be talking something to do with some VT ablation and signal everywhere. Deepak, welcome, and then you can start your presentation.
Thank you, IHRS, for the opportunity. And I'm presenting after two very eminent presenters, almost like, as I say, Vijay Shankar coming into bat after Rohit Sharma and Virat Kohli. Let's see if we can keep the momentum. The Indian middle order was always the weak point. Let's see where we are right now. Okay, the key objectives of my talk essentially for today is, or rather it's a case presentation. What is the role of pre-procedure imaging when dealing with a ventricular tachycardia? Recognizing abnormal substrate on electroanatomical mapping, especially when the ventricular tachycardia is not going on. What is the symbiotic use of entrainment and substrate mapping? And finally, some little tips or discussion on epicardial ablation. Our cases are mainly done as a group, and all the procedures that we end up doing is a combination. We have at least 2 operators in for major cases, so that 2 eyes are better than 1. So that's what we look at. So briefly, on history, we have a 56-year-old male, previous history of inferior wall myocardial infarction, presented with resuscitated sudden cardiac arrest. At the time of resuscitation, monomorphic ventricular tachycardia was noted, which was hemodynamically unstable, needed synchronized cardioversion for reversion back to normal sinus rhythm. There were no other comorbidities other than the previous history of inferior wall MI, which was just thrombolized. The sinus rhythm ECG, and I don't have it right now, my apologies, showed the sequelae of healed inferior wall myocardial infarction with no persistent ST elevation. The echo was suggestive of an ejection fraction of 42% with a regional wall motion abnormality in the RCA territory with scarring noted there. There were no aneurysms and no clots were present at the time. Given the fact that the patient was not going to afford an ICD and the fact that it was hemodynamically unstable, we went ahead with the decision of taking him for an EPS RFA ablation under 3D rather than attempting to do medical management. According to the protocol at our institute this was the ECG at the time of the VT. This was a clinical ventricular tachycardia. And as you can see, you have lead 1 positive, lead AVF negative, early transition, small r in V1, but critically in leads 2, 3 and AVF, you can see a flat QS pattern, suggestive of perhaps no depolarization occurring in from the epicardium to the endocardium at this, suggestive of no depolarization occurring from the endocardium into the epicardium at these locations in the inferior wall territory. Also, there seems to be a slight slur that you can note in the in lead 1, perhaps in lead 3, and maybe in lead AVL, suggestive of perhaps an epicardial location rather than just a pure endocardial location. Again, these are just ECG-based thoughts that we had. We went ahead with doing imaging for this patient. You can clearly see in the imaging that there was no evidence of any inducible ischemia, as well as the MRI was suggestive of neat transmural scar that you could see in the appropriate territory. There was no hiatal hernia noted, and there was no prominent left lobe of the liver that we noted. We also were able to kind of look at the track for an access with the epicardium in the subxiphoid region. There did not seem to be any abnormal structures in that region, and we were able to plan for that at the get-go. Our setup, as usual, was vascular access with the right femoral vein, 8 French, 6 French for venous access, RV catheter. We decided to go a transseptal route since it was a posterobasal location of the scar, as well as recent experience at our center has shown that there is an increased amount of MRI-based white matter lesions when you go the retroaortic route. Left femoral artery, 4 French arterial monitoring was used. RIJ7F CS catheter was given so as to ensure that we have adequate understanding of where the atrial signals are and if there is inadvertent AV block, especially since the scar was in the posterobasal region. Epicardial prep was done for access. The mapping system used was CARTO, and we always use general anesthesia for our cases. The VT was induced prior to the onset of general anesthesia, The VT cycle length was 360 milliseconds with a QRS duration of 156 milliseconds. And as clearly seen in the previous ECG, there was a QS pattern noted in the inferior leads. Additionally, it was important for us to note that at the time of pericardial access, we placed our original catheters. We ensured that heparin was not given at this point of time and made sure that the wire moved freely within the pericardial space prior to putting in any sheath. Once pericardial access was obtained, these were the signals which were noted on the catheters. As you can very nicely see here, CS56, CS78, and CS910, I don't have the signals here, were showing scarred ventricular signals, suggest to epicardial substrate, something that we could correlate in from the MRI also. The location of the CS catheter is as shown here, and these are your sites which can be seen on the EGMs here. So entire posterior, lateral, inferior is where we suspected the scar to be. As you can see, the MAP catheter also showed delayed late potentials as seen during sinus rhythm. We proceeded as per the protocol at our place, proceeded to create an endocardial substrate map. And as you can see here, the substrate map also coincides very well with the distribution of scar on the MRI. Additionally, we did something cute for the LAT mapping. We took the reference at the peak of the QRS, which was there, and found the time from the peak of the QRS to the end of the QRS. That's approximately 42 milliseconds. And then what we did was we adjusted the LAT segmentations to actually give us in purple color what the late potentials were. So all our late potentials were concentrated into this area in the basal posterior region, which corresponded to the area of scar which was seen. Signals which looked like these and were extremely late. This one was approximately 153 milliseconds after the reference. If you subtract approximately 42, it is approximately 110 milliseconds after the reference. These signals were also highlighted and tagged. This is how this signal looks fractionated. So if we were essentially to do a substrate ablation only, these would be the kind of potentials that you would want to target. Either late, if late with poor EGM quality, and as mentioned by Nair et al. In the recent paper, high degree of entropy. This has got some large signals, some extremely small fractionated signals. The fidelity of the mapping catheter, the 3.5 mm tip catheter that we use, prevents us from seeing this even more clearer, but high fidelity catheters like the HD Grid or the Pentaray would show these signals in much greater detail. After creating our endocardial map and our late potential map, we proceeded with inducing the ventricular tachycardia. We took very great care that we had the patient on vasopressors and we induced our tachycardia for the purposes of entrainment and with the idea that we would cardiovert immediately. Catheter was placed at the border zones at the time of this particular entrainment attempt. So this is our first site. As you can see, our map distal shows a relatively sharp potential with fractionation seen on the map proximal. This signal is probably just, the signal is presystolic in location. As you can see the signal corresponding to CS78, and both the signal on CS56, CS78, as well as this signal are essentially in the diastolic phase of the tachycardia or the VT. These are signals which are potentially, as described in literature, possibly in the isthmus region, possibly at sites where you could find circuits of VT. So since we already had the initial part immediately post QRS and the part immediately just before the QRS, what we were looking for is essentially this box where these signals would be found. So at this site number 1, we proceeded. This is the location in the VT map. At this site number 1, this was the EGM, and we proceeded to entrain at a cycle length just slower than the tachycardia, just faster than the tachycardia cycle length. If you can see my screen here, the last 4 beats are the ones where pacing has been initiated. Looking at the EGMs intracardiac, they have been accelerated to tachycardia cycle length. There has been tachycardia which is going on after the pacing in the ventricle, and the PPI minus TCL at this location is less than 30 with a stimulus QRS versus EGM to QRS of 0. This suggests a possible location within the tachycardia circuit, probably at the exit, which was something that we expected given that the EGM was also just pre-systolic. As with all reentrant tachycardia, it is important to figure out what the circuit is, because usually spot ablation does not terminate macro reentrant tachycardias. We proceeded to go further and we went to this site too. The site is furthermore within the diastolic time period of the tachycardia cycle length. It grows closer to this EGM on CS78, and entrainment was attempted at this site too. With respect to the previous site, this was the location of the pacing site. The EGM again clearly seen here. And looking at the entrainment, the first, second, and third beats are the one there entrainment occurs. It looks like perhaps a concealed fusion at these locations. Minor changes noted in lead V4, maybe lead V5, but all in all, a good entrainment 10 by 12 kind of a map. Post-pacing and post-entrainment attempt, tachycardia still continues. So we are still entrained the tachycardia. We haven't terminated it. The PPI minus TCL at this location is less than 30. Stimulus QRS equal to EGM QRS is equal to 60. So location within the tachycardia circuit is probably proximal to the exit, not really in the central part or way out here. We go ahead. Site 3 again becomes slightly more earlier than the previous site. With respect to the previous sites, it's right here in the middle. The EGM seems to be slightly more fractionated with an EGM that is large here. Unclear if it's the local EGM or not at this point of time. Again, entrainment at this site gave a very reasonable fusion on observation. Doesn't seem to show any significant changes. 12 by 12 probably at this site. Stim to tachycardia, PPI minus TCL less than 30. Tachycardia continues post-entrainment, so it's not a bad entrainment at all. Stim to QRS versus EGM to QRS is 80. So now we have determined 3 different sites pretty close by each other, one of which is the exit, 2 of which are probably within the isthmus of the tachycardia. So what do? We tried ablating here. Tachycardia would not terminate. So despite great entrainment, great signals, location of the EGM right within the isthmus of the tachycardia, right within the isthmus circuit of the tachycardia, the tachycardia would not terminate. So now we are left with finding out that box between the latest EGM on the CS78 versus these signals. Try as we might endocardially, we weren't able to get any better signals within the diastolic time interval of the VT to suggest that we could have done a better job here. We had epicardial access. We proceeded to put a sheath in. A deflectable short Agilis sheath was introduced into the epicardium. And these were the signals that we noted in the epicardium in VT. Note here, we did not do substrate ablation or substrate mapping. We went ahead directly with inducing the ventricular tachycardia. As you can see, we saw sites of late potential. We saw sites of mid-diastolic, early systolic potentials with preserved myocardium. We saw myocardium amplitude. We saw sites of extreme fractionation with probably mid-diastolic location, and we saw systolic locations. All of these were seen in the epicardium in VT. This was my catheter at the site of when we decided to start ablating at these sites. Entrainment was performed, and these sites were noted to be similar to the ones on the endocardium within the isthmus of the ventricular tachycardia circuit. Coronary angiogram obligatory to see whether or not we were close to any major epicardial coronaries. Pacing of phrenic was not performed at this location since it was not on the lateral wall and there was no previous cardiac surgery performed for this patient. These were your endocardial sites, and these were the sites epicardially. And when we ablated at these sites, moving the catheter gradually inching upwards from this location here in the LAO to this location more cranially, we were able to terminate the tachycardia. Ablation was done in the epicardium at 30 watts power at an irrigation of 5 ml per minute of normal saline. and continuous withdrawal or pericardiocentesis was performed during the procedure. As you can see in this was a set of endocardial lesions. These were the set of epicardial lesions. And if you can imagine, these are both in the same view. And this is slightly cranial and superior to these set of lesions, suggesting that perhaps this was the way to transect the tachycardia circuit. We obviously continued up till we reached the annular location where we anchored the line. If you look at the termination of the tachycardia here again, you can very well note that the tachycardia circuit has terminated between CS78 and the next ventricular beat here in diastole. So we have been able to successfully transect this circuit, which we had seen earlier. The box-like location, we were able to map that location. Only difference being that box-like location was not present on the endocardium, but was in fact present on the epicardium. Another interesting observation here is a site within the tachycardia diastolic location, diastolic interval. It actually becomes a late potential when it converts to sinus, suggesting that late potentials, mapping, and perhaps ablation in sinus rhythm may actually help us render tachycardia circuits non-inducible if either the tachycardia is hemodynamically unstable or in the lab you are not able to induce any tachycardia despite having demonstrable clinical tachycardia. Post-ablation, non-inducibility was checked by two-side stimulation at 2 cycle lengths up to 3 extra stimuli. A figure of 8 suture was used to secure venous access. Epicardial sheath was removed. No bleeding or collection of fluid was confirmed. Glucocorticoids and lidocaine were instilled into the pericardial space. Pain relief was given post-procedure, and colchicine was added for this patient. We continued our anticoagulation 4 hours post-procedure, and the patient remained asymptomatic till follow-up, which is approximately 5 months since the procedure. In summary, unstable VTs, when we deal with them, we would like to induce the VT to ensure that we have a template and know where to place the catheter when attempting entrainment. Elimination of late potential and fractionated signals will be critical. If there is persistent VT, we need to check the cycle length of the VT, especially if you have eliminated late potential and fractionated signals previously. The cycle length of the VT may have slowed, which may allow you to then map the VT circuit itself. Make sure we reinduce for short periods of time to ensure that there is no hemodynamic compromise to the patient. Alternate sites present should be mapped, especially the epicardium, even if you get great sites of entrainment in the endocardium. Only ablation at sites within the circuit may not terminate the VT. We may need to transect the isthmus, which could actually be an endocardial epicardial isthmus, in order to achieve complete non-inducibility. Thank you for your patient hearing. Love to take some questions.
So Deepak, great case. Deepak, can you hear me?
Yes, sir.
Yeah, great case. I think it is worthy. All that the traces are worthy of putting it up in a textbook. Textbook case. See, Deepak, there is a problem here, and that is, I think you are biased with the epicardial approach. When you showed that ECG, this is an ischemic cardiomyopathy case. Okay. And look at that ECG. You tried your best to convince us and bias us that it could be epicardial. You know what? I would not have placed a stick there. All right. See, first of all, you are talking about a poor man who cannot even afford an ICD, and then you are bringing in this therapy. But he has to go home safe. All right. Not to stay in a hospital for a long time because you created a pericardial stick, and then there is a perforation, and then the stay. We are cautious, especially in ischemic cardiomyopathy. To begin with, thinking about an epicardial approach also could be all right. I think it is little extraordinary. That is not the recommendation, especially looking at your ECG. I think you could do an epicardial ablation in case in the first sitting if you are not successful. So safety is more important, right? But if you say on the basis of that ECG, you did an epicardial stick, we do not agree. If you say your approach in your institute is to go for an epicardial approach all the time, any VT, we would put a stick. If you say, we will take it. But based on that ECG, if you try to tell us that we should stick one pericardial an approach stick there, we do not agree with you. Now defend yourself.
Sir, in case of lateral myocardial infarction or lateral scars, if there is any kind of endocardial to epicardial conduction, you will always see a small R. The absence of that small R in a ventricular tachycardia indicates that your site of origin is actually epicardial.
Right.
As far as this patient also goes, similarly in an inferior location, even though it's a bipolar lead, 2-3 AVF are bipolar, you may not use the same criteria that you would use for a lateral wall where there are unipolar leads actually looking at the QRS morphology. In the inferior leads also, it has been shown, and there are papers to show that if there is the lack of that small R in the VT, it is still coming directly from the epicardial surface. Again, coming to the point of it being a poor person or finances, the more number of cases you do, the more will be your benefit, number one. The more experience you'll get, number two. And finally, the same patient cannot come back. You will have to...
Fair. Let's not get into the economics part. But you see, looking at the algorithms which have been practiced, looking at the clinical substrate, ischemic cardiomyopathy with this kind of an ECG, epicardial location of the scar is, anything is possible in medicine. But in this case,
we had an MRI. That is why pre-procedure imaging is again critical.
Perfect.
Have MRI. If it's not a transmural,
okay, let's not argue. So your approach in this case was based on the ECG clues of epicardium, and that is why you put the stick, or you do stick every time?
We don't stick every time, sir.
Good. That settles the issue. So you have more insight. You looked at the ECG criteria, which is not very well. These, whatever you told, they are not very well accepted criteria for the epicardial. Some reports are there, but they are not the general guidelines for the epicardial location of the scar, right?
Sir, again, this exit. It's not necessarily the scar needs to be there. The scar in an ischemic cardiomyopathy could be anywhere. The exit could be anywhere. If you are dealing with transecting the isthmus of a reentrant tachycardia, the exit does not make a difference because the exit on the ECG is only where it is.
No, fair.
Transect the isthmus.
So you know what? We learned several things here. We looked at the imaging, and then you talked about some of those very nuanced findings on the ECG, where you thought we should stick the pericardium, but in general, I think in a ischemic cardiomyopathy, you can take two times, and then maybe you do a good job on the endocardium. More often than not, endocardially also you can be successful. But in your case, epicardial thing. Parikshit, your comments and your expert opinion.
So again, we do a lot of VT ablations, both endo epi. But my approach and our approach has generally been, again, I would have to side a little bit with Dr. Ullas here. For ischemic VTs, or ischemic cardiomyopathy, we tend to start endocardially. And again, we do have the benefit that if a VT recurs down the road, we can bring them back with a plan for an epicardial approach. But our first attempt usually is endocardial. For a non-ischemic patient, on the other hand, we know a lot of this substrate really sits epicardially because scarring tends to occur more perivalvular, either perimitral or peritricuspid valve, and most of the scar sits epicardially and doesn't extend all the way to the endocardium. I think the key thing to remember is with VTs, we've gotten used to thinking about things two-dimensionally, and it is a three-dimensional circuit, right? It could go from endo to epi, it can go from endo to mid-myocardial or epi to mid-myocardial. It's just about how do you get to the critical portion of the circuit to be able to terminate the VT and prevent other VTs from occurring. So, I think the first thing here is the advantage you had here, Deepak, was the fact that the patient had a VT that was hemodynamically tolerable. We don't often get those lately, and we have to think, I think the most important thing is, yes, if you're going to do this, and the best way to do it is to be able to induce VT and MAP during VT, think about proactively hemodynamic support, whether it be vasopressors, whether it be an assist device of some sort, and rarely, if a patient's really, really sick and we have to do these, even ECMO. So all of those are options. There's two other questions I had for you, Deepak, one was when you were doing the pacing maneuvers for entrainment, what was the output that you paced at?
Just above the diastolic threshold.
Okay, so it did look like some of those entrainment maneuvers demonstrated more manifest fusions, which suggests to me definitely during close to the exit site, which it could capture tissue around the exit site. But it was not a absolutely 12 out of 12 or 24 out of 24.
Most of them were 10 by 12, I agree.
Exactly. And then finally, when you ablated endocardially, what were your power settings, and was it normal saline or half normal?
I love using half normal saline, but for this, we hadn't used half normal saline. We did use normal saline. We went up to a power of 40, given that we were against the septum irrigated catheter 40 at a flow rate of 30 ml per minute. But unfortunately, we weren't able to succeed there. The line was created, but
how long were the lesions?
240.
And then you actually demonstrated loss of capture after you finished the bleed.
That is done at all. That is done at all.
Yeah. So, we've actually seen that switching to half normal, and we actually have gone, not with half normal, but with normal saline, gone up to power settings of 50 watts. And I know it's, you have some puckering at the time, but you have to do that when you're in the left ventricle sometimes, especially the circuit is more three-dimensional, as we see very clearly in this case. One of the other things I think would be helpful in cases like this, especially if you do not get a long duration of hemodynamic stability during VT, is to use multipolar catheters. So we often would use either a pen array, or if you're using ESI, you could probably use the HD grid, so that that entire diastolic period you can actually demonstrate the entire circuit. And we've seen cases where we've demonstrated the entire circuit on just the pen array. And you can tag those points, and even if the VT is hemodynamically unstable, you can go back to those areas and perform substrate-based ablation, just so you know exactly where to go. So yes, this was a beautiful case. We don't always get lucky to be able to perform every entrainment maneuver at different pacings at different sites, which is great, but having a multipolar catheter can get you quick information on substrate, and then you might just induce VT the one time and get all the information you need, maybe perform pacing at one or two spots, and then just go ablate there. So for ischemics, I think whenever we've switched to half normal, we've been able to get a deeper lesion and not always have to go epicardial. You get enough of the circuit where you don't have to go epicardial. But yes, I mean, part of the circuit could run mid-myocardial, go into the epicardium, and come back endocardially. I think it's a little bit tricky when you look at ischemic cardiomyopathy and try to determine based on your surface ECG if the circuit is epicardial or endocardial, because oftentimes it's an extensive scar and it is transmural, and you have to perform ablation at both sites sometimes. So it's best to start endocardial, and then if you have to go back epicardial if there are more VTs. My final point was, in addition to the
Parikshit, you know what? Let's take up some questions here.
Sure.
Aparna has a great question, which was actually in my mind too. She wanted, Deepak's presentation was great, is a textbook, but what was incomplete, which Aparna has picked up, is something to do with the unipolar mapping, which is another great stuff to figure it out, the epicardial location of the scar. But then you probably have an excuse there, because in the CS you could demonstrate those potentials, which is like already that there's a scar there and it was corresponding to your entrainment sites. But is that the reason why you did not really waste time in looking at a little more in detail about the unipolar map? That's one question. And the second question is from whom is that? See, there is this, distribution across the country. Some people do the CARTO, some people do the HD grid map with the Insight. I think you are one of those privileged ones. I think you have the experience of both. Jaydev has a big place. So let us know, like what? Do you find any advantage here? You use CARTO. I think you have an Insight with you there. So why did you pick up, for example, this particular case under CARTO, for example? Let's know about that too. So for the Aparna's question about the unipolar and this HD grid versus CARTO.
I think Aparna Madam has a great question. If I didn't have the imaging, that's what I would have done. I have an MRI prior. I know where the scar is. So for me, although it serves as a guideline for me to say, okay, look, you had unipolar scar, which was measured from the endocardium, which showed epicardial location of scar. But if you have the MRI, you already know where it is. So that's why I have not shown it here. But yes, 1 to 8 could have easily been set up and you could have figured out what it is. As far as CARTO goes, CARTO is more easily available for us rather than having the NAVEX system to be used on a day-to-day basis. So that was a choice. But here is my take on HD grid versus pentarray. If there is an ongoing VT, if there is an ongoing arrhythmia that needs to be mapped in arrhythmia, I would prefer the HD grid. The reason is it is contained. The splines of the HD grid are contained within the wire framework. It allows me complete control over the catheter tip whenever I'm doing a procedure. The pentarray is great if I don't really care about the procedure in terms of the activation mapping, and I'm just looking for some kind of an anatomical shell, maybe my AFs, where I just need it to go in and out. I needed to make a quick anatomical shell for me to be able to ablate it. That's where I would use my pentarray. Again, substrate wise, I don't really know of enough studies which have compared the two. Does pentarray find out more substrate versus HD grid? But given that you do have perpendicular vectors present on the HD grid, you would imagine that they would pick up substrate and channels much better as compared to the pentarray, which is essentially flailing away in all directions. So that would be I hope that answers the question. If I've missed anything, please do let me know.
Deepak, fantastic. All of us learned so very much. Your traces were beautiful. And then the clock says it's 8 o'clock. Vanita, Parikshit. So Parikshit's final comments and Vanita, concluding remarks. Deepak, Shunmuga, Suchit, wonderful. I enjoyed the session.
Yeah,
and then of course, all those people who had logged in and they have asked the great questions. It was really, really great learning for all of us.
Yeah, I think they were all fantastic cases. I think everyone put a lot of effort into it. I mean, it's fantastic to see all this great work that all you guys are doing, and just be able to be here to learn from all of you. So thank you for the opportunity, and hopefully we can do this again.
So thank you so much, Parikshit, Ullas. It was a great session, and all the three speakers, Deepak, Suchit, and Shunmuga, you are our pride, and you did a good job. Parikshit, we should have more of you here. You have promised that you will be
if we can make it Saturdays, I promise I